Good evening, everyone. I am Dr. Karen Carrasquillo, BostonSight's VP of Clinical and Professional Affairs. Welcome, and thanks for joining our BostonSight SCLERAL webinar tonight titled, So You Want to Fit Scleral Lenses. Tonight, we're not only going to teach you how to fit BostonSight SCLERAL and go over the key features of our lens design, but also we will discuss and go over key fitting and troubleshooting fundamentals to achieve patient success. Hosting our webinar tonight is an amazing expert, key opinion leader and clinician, Dr. Vishakha Thakrar. Dr. Thakrar is a residency trained in cornea, contact lenses, and refractive surgery management. And in fact, she was trained to fit scleral lenses at BostonSight in 2001. She owns a specialty contact lens practice in Vaughan, Ontario, where she primarily sees patients with corneal and ocular surface disease. She previously held the role of Director of the Contact Lens Service at the Cleveland Clinic and has spoken on contact lenses throughout Canada and the United States. She has been a contributing editor for Contact Lens Spectrum, Eye Care Review, and Optometric Management, and has written numerous articles both for the Canadian and American journals. She is a fellow of the American Academy of Optometry and the Scleral Lens Education Society. She currently sits on the board for the contact lens section of the CAO and is a principal organizer for the CCLA conference. We're truly honored to have Dr. Thakrar with us. And we also had an amazing expert and speaker hosting the webinar tonight, Dr. Jennifer Liao. But her first newborn decided to grace us with arriving to this world ahead of schedule. She actually had her baby boy last night. So unfortunately, she cannot join us tonight, but we send Dr. Liao our best wishes. And we're truly grateful, both Dr. Thakrar and I, for her collaboration actually in the preparation for this webinar. So I'm going to step in and I'm going to be hosting the webinar together with Dr. Thakrar. And at the end, I'll be moderating the question and answer section, which I really encourage all of you, if you have any questions as they come along, to please write them down and channel them through the Q&A panel section. And at the end of the webinar, I will go through the questions and then we'll have a nice discussion with Dr. Thakrar. So let's get started. So as a matter of introduction, for those of you who already know about BostonSight and BostonSight SCLERAL, thank you for being here with us. But for those of you that are new to BostonSight SCLERAL, just a little bit of background about us is that our goal is and has always been really to partner with you and help you achieve patient success with predictable fitting endpoints and fewer lens modifications when you fit your patients with scleral lenses. And so with that goal in mind, we launched a product in 2017 designed to package a lot of amazing and key features to be able to achieve such success, but to do so in a simplified manner. And that's why BostonSight SCLERAL is a lens design based on data and objective patient outcomes. Tonight, we're going to be going over all of the different built-in features that this lens design has, but it's important to highlight that all of these features that we'll be talking about are actually included over an extended diameter range from 16 to 19 millimeters. By expanding our diameter options, all the way from 16 to 19, we're really empowering you to make the best choice for your patients. We have 2 triple play fit kits. You can see the schematic of the cover of these kits, where you have 2 kits. Each kit has 3 diameters. Each one has from 16 to 17. The other one has lenses from 18 to 19. But we also have an empirical lens feature called Smart 360, and we'll be talking a little bit about that as well. The Smart 360 empirical feature is currently available via the Eaglet Eye ESP, and later this spring will also be available via the Pentacam CSP. So at the heart of what constitutes our data-driven design is the fact that these lenses, all of the trial lenses, including the 16 all the way through the 19, they have built-in scleral shape in a quadrant-specific manner, or a different term would be they have built-in scleral toricity in a quadrant-specific manner. All of these trial lenses are quadrant-specific. But additionally, in these 2 triple play fit kits that you all have available, we also have built-in oval optic zones. Regardless of the diameter, what this allows and helps is that it results in better lens centration and predictable and reliable fitting endpoints. Really, the goal here is if you don't have a corneal scleral surface profiler or an instrument to map the scleral shape of your patient, is to avoid the need for these special equipment. And by doing so, we would maximize your efficiency and patient comfort. These are some of the data-driven features that we're going to be highlighting tonight. These are the data-driven features. And as we speak about them tonight and how can they help you obtain better patient outcomes, is actually also good to highlight that these features are at no added cost, is an all-inclusive price available for you. If you're someone that is into technology and would love to leverage the ability to do empirical fitting, and you have access to these instruments, you could do that with our Smart 360 feature. And as I mentioned earlier, we have 2 platforms available now, the ESP and very shortly the CSP. And what that will allow you to do is that regardless of the instrument or the platform that you're using, this is an example here of an image or a corneal scleral image from the Euclid Eye ESP, and this one is from the Pentacam CSP. So regardless of the instrument, you acquire the data and you can push that data through our online order and management system, FitConnect. And from FitConnect, the data goes straight to the lab for manufacturing. So basically, as the term says, 100% empirical fitting. You can take advantage of the fact of using a trial lens to obtain over-refraction, or you can use refractive data from previous RGPs in order to do this. And it is possible to obtain outcomes like this, regardless of the platform that you're using. And so leveraging the power of data and science for us truly goes beyond the fit. We do have great features to empower you to get better fitting endpoints, but with BostonSight SCLERAL, you also have the benefit of years of experience and data reaping the benefits of SmartSight technology, which is taking advantage of different front surface eccentricities for aberration control or mitigating aspects of HOA. And all of this really at your fingertips, literally, because you have these trial lenses within your fit kits and without the need of special equipment or instruments. But with our SmartSight HOA collaborator, or Smart HOA technology and our HOA collaborator program, we also work with you to provide you custom HOA correction for your patients. And really the goal here is obviously to provide your patients with the best quantitative and qualitative vision possible.
Karen, before you move on, do you mind if I jump in and just make a comment about that?
Yes, please.
I have found, I've been fitting scleral lenses and using all kinds of different companies for many years. I love the fact that you have aberration control built into the scleral lens. So, you know, a lot of the time we have patients coming in, whether it's keratoconus or whatever, you know, higher order aberrations they potentially have as a result of their disease, where you fit them, you can get them to 20/20 or 20/25, but they're constantly complaining of ghosting. And so this is something that I've found in my time of using BostonSight that really elevates these patients who have been struggling with their vision. And I mean, typically, a lot of times you see this with those younger male patients with the big pupils. And so I haven't yet, I mean, I'm excited to one day use your, you know, higher level aberration control, but I've been able to get what I want out of just the fit set, which I think is pretty impressive on your part.
That's amazing. I'm glad that you're finding that to be the case. You know, as a clinician offering pros treatment, I had the ability to offer and manipulate front surface eccentricity for patients. And like you said, at the time early on when we started, or I started, I should say, back in 2006, 2005, we didn't have access to these great aberrometers that we have today. And
Exactly.
so having the ability to manipulate the front surface eccentricity was invaluable because of what you say. Patients do report less ghosting, less glare, better quality of vision, and we can all relate, right? That 20/20 is not the same for you and I. We're very fortunate, right? But for our irregular cornea patients, they can read 20/20, but the quality of that 20/20 we know is challenging and can be subpar at many times. So when we launched this design, it was clear to us that we needed to come up with a way of offering this in a simplified manner that you can all take advantage of it, and more importantly, that your patients can take advantage of this. So yeah.
I mean, the benefit is very, very obvious to me in the months that I've only been fitting this lens. I really appreciate that.
That's great. And you're going to be sharing some cases later on as well, correct?
Yes, I will be.
Wonderful, wonderful. So just closing the loop on our features. So having the option to vault, customize your scleral lens fits by being able to vault anatomical obstacles is an option that you may be familiar, perhaps with some other lens design. We use a patented technology called Smart Channel that will allow you to vault these anatomical obstacles in your patient scenarios. But also, we want to talk today about a different option that you have at your hands, and that is the option to use this Smart Channel technology to promote tear exchange and eliminate or minimize suction in cases of compromised ocular surfaces or compromised grafts. And I believe, Dr. Thakrar, that you're going to be also talking a little bit about that later tonight. Yep. So anchoring our data-driven design and all of these smart features is our online ordering management system, which is called FitConnect. FitConnect truly puts the power of lens design and order management in your hands, or the hands of your practice staff. You can design lenses and actually benefit from seeing if you need to make a tweak or change. You can see by the graphical representations how that design is actually changing in real time. So it's very helpful as a fitting tool. But you can also, either you or your practice staff, be able to track your shipments, access your account billing, print prescriptions, and much more just with a click of a button. And the great thing about FitConnect, other than the fact that there's no added cost, is also that the platform is screen responsive. So you can access FitConnect from anywhere at any time, from your iPhone to your iPad to your PC. So you don't really have to be confined to your clinic or office. And that's really very beneficial. And as I said, there's no added cost to this.
Can I add something also about FitConnect? It's great to be able to have the flexibility to make your own changes. The one thing I want to just give a piece of advice to everybody, to the audience, is that a lot of us have fit 16 and 17 millimeter lenses pretty regularly. So the way that you would adjust a larger diameter lens, an 18.5 lens, for example, is going to be a little bit different than a smaller diameter lens. So my suggestion is when you start into FitConnect, you may want to, there's a box you can check off, hold for consultation. I think it's really great to really learn the intricate details of a specific design from the consultant themselves. Like go through that, go through your specific case with them before you do everything on your own, because I think that will shorten the chair time eventually if you're learning how to do it right off the bat.
Absolutely. And a great feature about that hold for consultation is that if you don't have the time right that second to get on the phone, because we're also busy, the great thing about FitConnect is that when you click hold for consultation, you write in detail what is it that you need. Either you need us to call you, or you just need us to do a particular thing to your lens design. And then what that will do is that it sends the order in a queue. the lab won't process the order until the fitting consultants actually review your order, and whatever you ask, that will be done. So it's an opportunity for you to really write detailed instructions or descriptions. So I'm glad you brought it up, Vishakha, because yeah, that's another great tool. All right, so changing a little bit gears, let's just talk, now that we discussed the features, let's move on into how do we fit these lenses, and then Dr. Thakrar will take us to cases, clinical cases. So when we set up to design this data-driven design, part of our mission was also to come up with a simplified fitting algorithm, one that didn't require elaborate calculations or the need for instruments. And so when you fit BostonSight SCLERAL, the first thing you will do, and I need to highlight that, is to choose the diameter. You have a range of diameters to choose from. So the first thing is to choose the diameter, and following, we'll discuss different scenarios where you might want to consider which diameter to start with. Once you've chosen your diameter, it's very simple. We recommend that you always start at the middle of the lens. You're going to have 3 lenses per diameter. These nomenclature, standard, flat, or steep, what that nomenclature refers to is to the scleral shape or the scleral toricity that is built into these lenses. So the standard or our go-to average scleral shape is a specific pattern of toricity that is added in a quadrant-specific manner to the lenses, and we recommend that you start there. If with the standard distribution, which by the way, over 70% of our lens orders are fit based out of the standard distribution. So your patient is very likely to be in that 70 to 75% of the patient population. But if you happen to deal with an outlier that is in this 30%, and when you put the standard scleral shape, that is too loose, it's decentering, you have a lot of bubbles coming in, instead of guesstimating how much toricity you're going to add or steepening the haptic in a quadrant-specific manner, we recommend that you move to the right of your set and use a steep scleral shape with added toricity in the sclera. And that is also highlighted by the dark gray color, symbolizing that we're adding toricity. If with the standard scleral shape, your lens now is too tight, you have impingement pretty much all over, instead of guesstimating, again, how much you're going to flatten, we recommend that you move to the left of the set with the flat scleral shape, and here symbolized with a light gray color because we're subtracting toricity, so it's a lighter color. So visually as well is a very simplified fitting algorithm, and that's all you need. And so in speaking about lens diameter, I told you all first choose the diameter. And so you may ask, how do I know which diameter to choose from? As we said earlier, really, you know your patients better than anyone. So you choose the diameter that you think is best. But as a mode of suggestion, we recommend working with a 16 to 17 millimeter fit kit for patients that have small HVID, small apertures, tighter lids, pediatric patients, obviously, but also patients that may have a regular HVID, but then just have really difficulty handling the lenses. And if you're dealing with more regular corneas, right? On the other hand, we recommend to switch to the 18 to 19 millimeter fit kit for corneas that are very protruded and highly ectatic, because that will help distribute the weight of that lens over a larger surface area, and you're going to have less issues with compression, and your patients will appreciate you choosing that. For larger HVIDs, definitely for compromised grafts or fragile corneas, compromised ocular surfaces. In cases of chronic exposure, we know that exposure and dryness goes beyond the cornea, and the conj is also affected. So covering more of that ocular surface is beneficial, and for severe dry eye. So this is a schematic of these two fit kits. When you open them, they're really, you open as a sleeve. On one side, you have right fitting lenses. On the other side, you have left fitting lenses. That is also a virtue and a consequence of this data-driven approach. During our data analysis, we found out that the scleral shape or anatomy of the right eye is actually different from the left eye. So we're providing you two different anatomical shapes so that you really reach that endpoint much more efficiently and do not have to navigate the scleral asymmetry on your own. So as I said, there's 3 diameters per set. Each row is 1 diameter, but for each diameter, you have 1 additional lens with an even higher sag in case you need a higher sag. And so when you start fitting the lenses, if the sag is too high, you don't need to worry that you don't have a trial lens with a lower sag. You just go to Fit Connect, and in Fit Connect, you can lower the sag there. So you have a total of 12 fitting lenses, and you have 2 lenses here that are just there with additional front surface eccentricities. Those are not fitting lenses. Those are lenses meant for over-refraction, and we'll talk about that in a minute. Both 16 to 17 and 18 to 19, they look the same. And so when we speak about the front surface eccentricity, again, a virtue of our data-driven analysis, all of your fitting lenses, as I said, there's 12 fitting lenses, they all have the built-in E1 value. And in fact, over 90% of our orders achieve optimal vision with the built-in value. But if your patient, again, is an outlier, and even with the E1, they're still saying that they have ghosting or glare, we recommend that if you're dealing with an irregular cornea patient, you choose the fitting lens that you're going to start and remove that lens. And then in irregular cornea cases, you actually try and increase eccentricity value. And in that case, you can move to the E2 value. And if you're dealing with a regular cornea patient, you start with the E0 value. It might be that at any point in time, you might need to try a second eccentricity lens, but in general, that's the rule of thumb and how to approach your patients. And you'd be surprised just by changing the eccentricity that you might actually improve the vision. Yes, please, Dr. Thakrar.
Do you find that with the normal corneas, if you start with an E0, it provides better vision than an eccentricity of 1?
So, when we did the data analysis, I thought that that's what we were going to find. And, we see it in our clinic, we see a whole spectrum of corneal diseases, all the way from dry eye, neurotrophic corneas to irregular. And E1 was predominant, even in our own patient cases. And after launch, we continued to track the data. And so across the spectrum, E1 continues to be the predominant one. But this is why I said, if your patient, you're dealing with a neurotrophic cornea, dry eye, that it's a regular corneal pattern, and the E1, they don't respond well, the first lens, instead of going to the E2, the first lens I should suggest you try is to try the E0.
And when you say don't respond well, do you mean vision? The vision is not as good as you'd expect it to be? Right.
They might say that we might be inducing some aberrations or some distortions. So a regular cornea patient may tell you, I actually see a little bit of ghosting, or there's something about the vision that is not sitting well with me. And so that's kind of your hint. And so my suggestion is to start with the E0.
Excellent. It's a great option.
All right, thank you. So all of our trial lenses are laser engraved. That's actually great for identification purposes. It's a very simple legend. It starts with the letter, is the series of the sign, either R or L for right or left. Then follows by the lens diameter number, 80 for 18, 85 for 18.5, and so on. Then you have the lens number, 1 to 12, and followed by the eccentricity. You're going to have lenses either with E1, which are most all of your fitting lenses, or E2 or E1, or E0, I'm sorry. All of our lenses are dotted for identification, right or left. 1 dot is right eye, 2 dots is left eye. Most of these lenses will sit in an oblique manner. So when you see the lenses sitting obliquely, don't try to remove them and reapply. That's how they're going to sit most of the times. We have a very easy engraving system in all of the meridians. so that regardless of where the dot is sitting in the eye, Dr. Thakrar, you probably have seen this. If you need to modify a meridian, all you need to do is pay attention, look at the haptic, and see which number it is. And that's how you know in Fit Connect which meridian you need to make a change. So you don't have to track the dot position or anything like that. And both trial lenses and patient lenses have an engraving. It's very important when we deal with patients. I'm not sure if you can relate to this, Dr. Thakrar, but I've had patients that sometimes come wearing older lenses or mixed the lenses, and maybe the dots have disappeared. And so having the ability to track the lens number in the lens, it helps for identifying them, right?
It's a fantastic feature. Even when patients are exchanging lenses and they return the wrong one or whatever happens, you can track it.
Exactly.
Otherwise, you lose complete control over it.
Exactly right. So, you know, we have that available for you. And so the last thing I will say before I hand this over to you, Vishakha, to take the audience through these wonderful cases that you have tonight, is that if you all need to, your patients need residual astigmatism correction, know that this is an option that is available to you. We do recommend, though, that you make sure that your lens fit is rotationally stable. If you have a non-stable lens and there's some spinning, if you add astigmatism correction in the front surface, you might be chasing your tail. So that's rule number one. And then number two, once you proceed to, you think you want to do this, my recommendation is try the eccentricities first. There's a paper by Michaud et al. There's actually saying that a lot of the residual astigmatism is not really from lens flexures, but it could be from actually some high order aberrations. So try changing the eccentricity, because sometimes we have seen that with the eccentricity, we can mask some of this residual still. And if with that does not resolve, then apply the front surface sill residual. And what is very important, and some clinicians forget, is that we use the dot position in degrees to be able to compensate your Lars, right? Left add, right subtract, and properly accommodate the axis of your cylinder correction. You can do that very easily with your slit lamp rotator ring, as shown in this schematic here. And then, you know, you can just go to Fit Connect and proceed to add the values there. But it's important that you notate the location of the dot in degrees. All right, Dr. Thakrar, so over to you.
Thank you, Karen. And I have to say, even though we decided to do all this day before yesterday, it's great doing this talk with you. And I'm sure both of us miss Jen a lot. And I'm sure, knowing Jennifer, she's probably on here watching. Probably. I have to tell everybody. So she and I, we were putting the cases together, and all of a sudden she texts me and she says, my water broke. And I'm thinking, oh my God, what's going to happen? Well, while she's in labor, she's changing the cases to this presentation. So I actually had gone through it and we were on Google Slides, and all of a sudden I go back to the presentation and I'm like, it's different than when I went through it an hour ago. And so this is like the dedication of Dr. Liao. I hope I get a chance to speak with her one day again in this topic, but she's a superstar. What a trooper, and congratulations to her.
Congratulations, absolutely.
So, you know, Karen, I'm just going to try to see if I can get control of the screen. Here we go.
There you go.
So, you know, I want to reiterate what Karen was saying, is that there's a lot of really great options to this lens. I think that on a practical basis, there are so many things that I think we as scleral lens practitioners have to problem solve when we fit patients. It's not like, you know, often when we are getting lectures done on how to fit lenses, it seems very, you know, straightforward and easy, but we all know it's not, right? There's a lot of changes that potentially need to be made to lenses. And sometimes we sit there and we look at those lenses and on eye and say, okay, now what do we do next? And what I love about the BostonSight lens is that there's so many options that are available that aren't potentially available in a lot of the other fitting sets I have. So, I mean, it's refreshing. It's refreshing to be able to give patients these solutions. And the reason I circled spline curve technology is because Karen had touched on everything else. And in my cases, I am going to touch on it again. And I'll tell you, some of my cases are BostonSight lenses and some aren't. We really just wanted to highlight some of the features and some of the potential issues that you may be having, and really encourage success in contact lens fitting. But with respect to the spline curve technology, I did my residency at BostonSight 19 years ago now. And that was one of the first features that really they explained to me. And I wanted to highlight it, particularly because what I found with spline curve technology is it gives you the opportunity to change curves without having any dramatic change to any other part of the lens. So you can even change, like say for example, oh, I want to change the 4 o'clock position in the haptic at the edge. I can give that information to the consultant and they can change that small little area because of things like the spline curve technology, right? That may not be available in all lenses where you're dealing with absolute junctions and trying to deal with flattening through those junctions or through those curves. So, I mean, it does give you flexibility, and I appreciate that with all the complicated patients that I see. Okay, so when Jen and I were discussing what we're going to talk to you about, we really wanted to give you the fundamentals of success. And what that meant is, you know, tearing down what we do inside the clinic ourselves, looking at those patients and the difficulties we may have, and finding success for that, finding the solutions to provide the best fit for our patients. So what I'm going to discuss with you is, you know, how to deal with anatomical issues in the sclera, dealing with lens decentration, which I think is a big problem across the board, troubleshooting visual acuity, which Karen and I had just alluded to earlier on, and then lens fogging, so anterior surface fogging. We don't have a lot of time today, so I'm only going to be presenting about 5 cases. So I'm going to try my best to get through all of them. There's a lot of interesting stuff, but again, you know, trying to make all of us as successful as possible. Okay, so let's get started. Before I present this case, I want to just talk about the anatomical elevations that we often see within clinic. So pinguecula is probably the most common one we see. This particular patient, if you can see where that circle is, and I'll use my mouse just to highlight it. So you see the pinguecula right over here. This patient is in the lens that the edge of the lens is actually butting up against the pinguecula. And as we all know, when that happens, it causes injection, it causes inflammation, and we don't see the whole conjunctiva here, but there's hyperemia extending through the conjunctiva. So we have a choice, like what are we going to do next? Are we going to decrease the diameter to get away from the pinguecula? Should we put a notch in? We can potentially make the lens larger, or should we vault over that pinguecula? So there's a lot of different options. And in this situation, because this pinguecula wasn't terribly deep, what worked really well is extending the overall diameter and really taking the weight of the landing zone and spreading it throughout the sclera itself or throughout the conjunctiva, removing the weight from the pinguecula itself. And if you see, you know, right over here, that's where the pinguecula is. And it's just very gently settling on top of the pinguecula. So there was no need to do a vault or a smart channel in this situation. I don't love notching, I'll be honest with you. I have notched lenses throughout my career. I always find there's injection and hyperemia in that area. I find the edges tend to be somewhat sharp for that patient, and it has to be completely rotationally stable. So I do find that that's a challenge. In this particular situation, they didn't go smaller. And I mean, I wouldn't even go smaller if even given the opportunity. And the reason is the weight would be distributed far closer to the cornea or even the limbal area. I think in this particular case, taking that weight out and gently settling it over the pinguecula was the better choice. And it really, I mean, it was a great fit.
So Vishakha, I'm glad that you bring this up and you're highlighting this as an option. You know, I remember earlier on when we were not really using this technology to vault over anatomical obstacles, what I would do is just what you said is, you know, what can I do, especially if as you said, the pinguecula is not too elevated or it's more flatly, you know, a little bit more flat or more wide. is just, I would just go larger, and just by distributing the weight, is all about, controlling that weight. And so when you remove that lens, my patients would have less rebound injection. And in general, which is what we're trying to alleviate, is the tenderness. Sometimes they were so tender because there was so much pressure over it. So I'm glad you're bringing that up.
And really the pinguecula takes on that pressure, right? Because it's the most elevated part of the conjunctiva. So I mean, yes, thank you for adding that as well. And it's interesting because in this case, this pinguecula is a little deeper, or a little bit more elevated, I mean to say. So in this situation, a smart channel was used. So what's really cool about the smart channel is you can completely customize it. So what was done is, if you look along here, this is, when measured, this is 170 degrees, right? So we can take the slit lamp, we can turn the light, and really track, as if you're measuring toricity, but track the angle where the pinguecula is starting and where it finishes. What you also can do is, when you're using Fit Connect, is choose how deep you want that smart channel to go. Okay, and this can be with any kind of vault, any kind of obstacle or elevated area that you have on the cornea or the conjunctiva. So in this situation, we went to a vault of 400 microns. Then, what's really interesting here is that, see how the pinguecula is right at the edge of the lens. Say the pinguecula was closer to the cornea itself. What we'd want to do is actually land back onto the sclera out here. So you can specify in your consultation notes, I want this to land 2 millimeters outside. Okay, so basically shifting that pinguecula over and getting an area that doesn't necessarily stick up, but can land again on the conjunctiva and be a nice soft landing. And this is, down here at the bottom is the Fit Connect. So you're actually able to view that channel in Fit Connect. So very cool feature. And this is another example of a channel where there's a conjunctival and corneal cyst. And look at how that channel was created. So I think it's pretty cool to be able to have a scleral lens fitting set in your cabinet that can do these types of things. It's so customized. So if you look at this channel, it's extending into the corneal space and on the conjunctiva itself, and landing nicely over here right at the edge. If you look at the fluorescing pattern, and it might be obstructed by our heads in the corner there, but you can see that there's nice clearance over the cyst. And this is another view of it. So this takes us to our first case, and this is Dr. Liao's case. I think it's actually a fabulous case. I think her imaginative thinking around solving the problems for this patient was absolutely fantastic. It's a 37-year-old male who presented with post-LASIK ectasia for scleral lens fitting. And she tried regular spherical and toric lenses on this patient. And as you can see, there is significant hyperemia, both with, I think she used another commercial lens and a BostonSight lens. And this was occurring in all situations. When the patient took the lens off, this is what you saw. And that is not what we want to see in a scleral lens patient. This is an angry eye. This is an eye just breeding inflammation, causing problems. And that that vascularization or that hyperemia can extend into the cornea and cause corneal issues. And the patient was also, Jennifer was telling me, he would see her in the waiting room and say, people are asking me, why are my eyes so red? Great, he can see, but sometimes the cosmesis to these things will stop a patient from wearing a scleral lens. They would sacrifice their vision for the cosmesis. So what she did actually, and not to harp too much on channels, but this is really cool. She put 2 channels in. So she put, for some reason, the slide is shifted downwards. I don't know if you can see the bottom one, but you can see the one that's on the right side, or the right lens. So this channel is almost 400 microns deep. Okay. What she was essentially trying to do is reduce suction, but take the bearing off of the 3 to 9 positioning on the conjunctiva, lift it up, and keep most of the landing superiorly and inferiorly. And it worked really, really well. I'm not sure if you're going to be able to see the final lens. For some reason, this is covering. I guess, is there any way we can shift it over, Karen?
Not, unfortunately, not at the moment, but you can see, that's too bad. But you can see the dramatic change. If you go back and you see that redness there, so both eyes, you can see in that outskirts there. I don't know what happened. That's bad.
Absolutely. Yeah, I don't know why it just shifted for the presentation, but as you can see, so this top one is the right eye. This is the left eye here, but what a difference. I mean, it's huge. And so that's something I think really thinking out of the box, where we're actually putting space in that area to relieve that pressure. And, there's certain considerations we have to, take into account with smart channels. And one is reservoir debris and fogging. So, I mean, if you have a patient like this and they get debris in the lens, say 6 to 8 hours through the day, I think they'd be okay with that, to take that lens out and clean it and put it back in, to not have that type of presentation. But Jennifer was saying to me, she's like, we really lucked out because he really had no fogging and he did very well. I also have to credit this case to Stephanie Ramdas, because when Jennifer moved back to Boston from Toronto, Dr. Ramdas took over this case and finished it up. So the next case I want to present is a patient of mine. It's a corneal transplant case. And if you see here on the temporal portion of the cornea, there is some microcystic edema. This patient presented to me, he's a keratoconic patient with a corneal transplant who, for some reason, was fit in a low decay soft lens for at least 10 years. And so it caused a lot of compromise to his eye. Before you ever fit, oh, sorry, I'm not advancing, I think.
Yep, right there.
Here we go. Before you fit a graft patient, always do an endothelial cell count if you can. You don't want to be surprised after the fact of putting a scleral lens on the patient and then having their endothelium not be able to support that lens. So I always get an endothelial cell count. Now, the interesting thing about this case is that his endothelial cell count actually looks pretty good. And you really, when you're doing that cell count, you're getting pieces of the cornea. You're not getting like a generalized count of the entire cornea. So this is demonstrating his central cornea. I see that often, I don't know if you do too, Karen, where I have patients present with a really nice clear graft, but compromised host tissue.
Oh, yeah.
And it could be because they're older, or it could just be from their disease state, but
Absolutely.
it happens quite often.
Yes, absolutely.
And so you're not so much dealing with the central cornea in terms of problems, you're dealing with the peripheral cornea or the host tissue. And so this is, this patient has an ectatic graft. This is his topography. And this is his eye with white light. So what you can see through here, and I don't know if you can see it clearly with your computers, but there's neovascularization 360 degrees around this right eye, okay? There is opacification. There's a tiny bit of encroachment of vessels into the graft itself, but other than that, he's got a nice clear graft. I had to fit and refit this patient several times because the issue becomes, with this type of protruding graft, as Karen mentioned earlier, you want to go with a large diameter lens. But an issue with a lot of large diameter lenses when you're fitting protruding grafts is suction, right? And so when you have suction, I would be potentially compromising an already compromised host tissue, right? And so it was very important to me to get the right fit for this patient. He's been in this lens that I fit him in for the past 6 years. The reason I brought this to your attention is I wanted to draw it back to the BostonSight lens, because I think the BostonSight lens gives a very important attribute with patients like this, where this particular patient, Karen gave me this slide, has also compromised to the host tissue. Now, if she fit this patient with a lens that potentially suctions on, what's going to happen to those blood vessels? They're going to become more engorged. They're going to spread further into the cornea itself and can compromise the graft itself. Well, what she did is put smart channels in, and the smart channels relieved any type of suction, but it also can give small amounts of change to oxygen to the cornea itself. And Karen, this is your case. Did you want to add anything to that?
Yeah, so it's absolutely. So what I would like to say is that when we use smart channels for these type of applications, Vishakha, it's important to share with the audience that we're not, in this instance, aiming for very deep channels. Really what we're aiming for is between 150 to 200 microns of depth. We just want enough elevation, from that haptic bearing surface so that it doesn't seal off. So that's the suction part. But also in doing that, we're allowing, promoting tear exchange. And as you mentioned, because the cornea receives oxygen, through the tears, these are oxygenated tears, it actually helps. And so this case, Vishakha, post-PK from Fuchs had actually edema, just like your case in the graft host junction, just on where that pretty nasty neovascularization is appearing. And just 6 months after, that's how that cornea looked, just by the addition of these 2 smart channels. We didn't play with the vault. We already had an optimized DK over T system just by addition of smart channels. So this is why it's great to share this with the audience when they're thinking about fundamentals of scleral lens fitting success, because if they have patients like this, they might want to take advantage of this.
Absolutely. And suction is such a problem, right? Because when we go back to fitting smaller diameter lenses, I mean, I find that circumlimbal hyperemia is often a consequence because if you're landing in an area where you don't have a lot of material along the haptic, you get more of a harsh bearing there on the conjunctiva. And that's, in terms of my colleagues who've asked me questions along those lines, I think this is really helpful to them. Okay. And even if it came down to increasing the diameter, that is also a helpful tidbit to help these types of patients who potentially have suction.
Absolutely.
Okay. So moving along. So this particular patient is an acoustic neuroma patient. So for those of you who are not familiar with acoustic neuromas, it is a type of brain tumor. It's a schwannoma that wraps itself around cranial nerve 8. To make that very basic. And then as we know, cranial nerve 8 and cranial nerve 7 are very closely tied. When this patient had surgery, they ended up with facial nerve paralysis, and the result is damage to the cornea. Now, this particular patient was lucky because if you look at this cornea, it actually doesn't look so bad, compared to some of these other acoustic neuromas that Karen, you and I probably see. The interesting thing about this patient is immediately on first glance, I look at him and I say, okay, this is a dry eye patient. He's got a normal shaped cornea, normal shaped sclera. No, I was completely wrong. So when I was fitting him, every lens I put on him, whether it was a small diameter or large diameter, was just flying off of his eye. I couldn't keep anything on there. So what I did is I called up the lab and I said, I need a lens. I think his sclera is very, very steep. I need a lens that's 20 millimeters. And I want you to steepen up the haptics for me so this lens can actually stay on his eye and I can get some sort of measurement. So this is what I got, and it did stay on his eye. But if you look at this lens, I mean, I'm showing you this case not because I think that you're going to have tons of these patients, because you won't. I've only seen patients that the lenses fly off their eyes probably 3 times in my career. So, but I am showing you this case because lens decentration, whether we're trying to fix this problem or fix a more, a more normal patient in our chair, we do the same things. So this is just showing a more dramatic example. So what I did, so this is again is a 20 millimeter lens. It's tucked under the lids. It's inferiorly decentering. You can even see, like, if we're getting close to the limbus, like, look how much clearance there is. The key to helping these patients is getting it on eye and centering that lens. So what I typically do, and I did for him, is I centered the lens. I took the lens superior and inferiorly, pushed it up, centered it, and analyzed every quadrant of that lens. Okay, so say, okay, I need to go steeper in this quadrant. I need to go, I don't think I needed to go flatter in any quadrant, but as an example. And I kind of specified how much I wanted to go steeper in each quadrant. I also, you can see how much central clearance there is. When I pushed it up, it gives me a good idea of the amount of clearance that I need to change this lens by. And so that would even apply to a lens like this. So this is a 17 millimeter, or actually a 16 millimeter lens that's slightly decentered, but you'll see that, early on in fitting, we would probably just look at this and say, there's blanching inferiorly. Let me flatten that curve. But that's not necessarily what we need to be doing. I think that's our first instinct, and it could be part of our problem solving as we go along. But what I would do is take this lens, hold it up, push it up. You may force bubbles in. If you do, take it out, put it back in, do the same thing. hold it up and find out where are all of my curves sitting? Is this actually aligning the sclera in all positions like it should be? And that will give you more information on how to line this up better and make the more appropriate adjustments in terms of centration.
What a great tip, Vishakha. This, what you've just said there, I think it's an amazing pearl, an amazing takeaway for our audience today. What you're just describing is the dynamic assessment of a scleral lens. A lot of people today rely on OCTs for everything, and that's okay. OCTs is great. I love using OCTs, but I love never to get rid of my slit lamp and their dynamic assessment, because OCTs will just see the impingement. But by you trying to see if that lens can move up and then holding it, you will see if it moves up, the lens shouldn't move up. If it moves up, it tells you that it's actually loose in that inferior quadrant, and then you need to steepen. That's a great tip. Thank you for sharing.
Well, I think it's so pertinent to almost all of the scleral lenses we fit, because as we know, it's common to have inferior temporal decentration of scleral lenses. And we want to know if it's in the right spot, how is it aligned, right?
Yep.
And that's the best way to problem solve. And so, there's other things we can do. And if you go, I mean, I've talked to most of these points, but if you go to the fourth one down, reduce sagittal depth if necessary. So what I did with that particular patient, the original one, is, I mean, the sagittal depth was huge, so I reduced it dramatically. But that's the case with any scleral lens, is that if there's too much sagittal depth, that lens is going to decenter because the lid is going to push it down. So that's something we have to look at. Floppy eyelid syndrome and heavy lids are a challenge across the board. Okay, so you could have the greatest fitting lens on the sclera, and you enter into, like, say, a keratoconic patient with floppy eyelid syndrome, and boom, that lens is being pushed down, right? So in that situation, if you feel like you've done everything you can to align that lens and it's still moving down, then you have to correct the change in that inferior position. Okay. But one thing I find that helps a lot with those types of eyelids is decreasing the overall diameter. And in general, decreasing the overall diameter sometimes helps. The reason is because the further out we get on the sclera, the more irregularity and shape change there is to the sclera itself. We are more spherical the closer we are to the limbus. Now, I'm one of those, I'm on like the side of larger diameter lenses versus the smaller diameter lenses in general, but when we're dealing with a really difficult to align fit, sometimes going smaller really helps us, okay? And so going back to my original case, after I think this was his third lens. So I got that first 20 millimeter lens that acted as the trial lens. I finalized the lens at an 18.5 millimeter lens, and it fit him beautifully. His cornea actually didn't look that much different than his original presentation because he came in wearing a soft lens anyway, so it was protected. But I Hydra Peg this lens, so he did not have fogging throughout the day. He could comfortably wear it all day, and he actually asked for a backup lens. It's so funny because one of his lenses was a -6 and the other was plano, because he loved having that 6 diopter reading ability in one eye. I don't know, it was strange, but it really turned out to be a really positive case that worked for so many reasons. But I want to add one more thing to this, and I didn't do it on my case, but it's something that I want to add with respect to a feature of the BostonSight lens. So going back to my original patient, oops, let's go back, sorry. If you put in an oval optic zone, so if you're drawing in, like putting in the optic zone right here, and it's oval. So when you're looking at the cornea is not fully symmetric. The HVID and the VVID, which VVID stands for vertical visible iris diameter, they're not the same. So it's interesting because the majority of my scleral lenses that I have in my practice have spherical optic zones. So if we introduce an oval optic zone, what that does is take these curves. So say we're up here, take these curves and push, say the limbal curves, the mid-peripheral curves, everything is pushed up. And so naturally, this edge or the lens itself won't decenter as much, it will be pushed up, right? And I think that's a fantastic feature that we need to really utilize much more frequently. All right. So, and I really just reiterated what I just spoke about. So we're going to move forward from this. How much time do we have? Do you want me to do another case, Karen, or do we want to, wrap up?
So maybe we can just wrap up with case number 4, and then we can just highlight just the highlights of case number 5 before wrapping up. I think we have about 7 minutes or 8 minutes or so.
Okay, great. So case number 4 is a newer patient to me. He had gone to multiple places looking for scleral lens fitting. And so his issue was he'd had LASIK over 15 years ago overseas. He did not have custom LASIK. He had traditional LASIK. So he was getting a lot of starbursts, very, very frustrated with these starbursts, and to the point where he's seeing 20/20 uncorrected, but he wanted to try scleral lenses. And he came to me specifically looking for aberration control, which, so he did his homework, right? And so he came in actually saying to me what specific lens he wanted. But the thing is, I have the BostonSight lens. So I said, you know what? I'm going to go with what I have. And it's a great lens to correct higher order aberrations. Let's try it out. As soon as I put the lens on his eye, so I just wanted to show you the topography first, because, sometimes when we have patients like this, we're dealing with ectasia, we're dealing with an center island, we're dealing with a decentered ablation. I mean, if you look at these, it's a centered ablation for the most part. So really his issue is more the small treatment zone and those starbursts, okay? Moving forward. As soon as I put the lenses on his eyes, okay, remember he had been fitted in scleral lenses in the past. This one, I fit him in an FSE1. So remember Karen was mentioning the different levels of eccentricity. This is the common eccentricity to use for fitting. I put that on him, immediately his starbursts were gone.
That's awesome.
Yeah. And for me, that's phenomenal. I'll tell you, Karen, my experience in the past with fitting patients with starbursts has not been terribly successful. It's different than the LASIK ectasia patient. The LASIK ectasia patient have corneal thinning and distortion, and you need to correct that irregularity, and you give them much better vision. But those patients who walk in 20/20 with ghosting or starburst, they're a lot more challenging to fit. And for me to put these are his actual lenses, but for me to put a trial lens on him and have instant improvement in starburst is pretty profound to me. And, it was amazing to him. Mm-hmm. Yeah, no, so thank you. I have to thank you
And
guys.
that's actually the built-in eccentricity. That's actually that's part of that 90% data point that we talked about earlier. That's great.
Absolutely, yes. It's the built-in eccentricity. So it's in the fitting set itself. But I did want to, this slide was given by John Gallus. It's one of his patients where he put on an eccentricity of 0, 1, and 2 onto a patient. And it was actually the least higher order aberrations, or the best aberration control was with the FSC1. So, really interesting to kind of take that as a tidbit that, the FSC1 can actually do a lot in this type of aberration control. Now, as an aside, I told this patient, like, if this is not enough for you to clear up, starbursts or ghost imaging at nighttime, we can go to a higher aberration control lens, or we can do a wave scan on top of the lens itself, as long as it's rotationally stable. So Karen was talking about rotational stability with toricity. When you're doing wave scans on top of scleral lenses, they have to be rotationally stable. It's absolutely imperative. It will not work otherwise, and you could cause more aberrations if it's not in the right place.
Absolutely.
So I told him, we have other options. If this doesn't work, we have other options. But fortunately, the FSC1 worked.
That's wonderful.
Mm-hmm. Absolutely. So it's 9 o'clock. Do you want me to touch on the last one, or do you want to?
So why don't you speak, what are the highlights of this case, and then we can wrap it up.
Yep. So, this, to go really quickly through this patient's case, she had radiation keratomas, I can't speak anymore. She has exposure keratitis from radiation to a tumor that was behind the eye. It affected her lids, and as a result, caused severe exposure keratitis, as you can see in this particular slide. I fit her with a scleral lens. She had profound improvements in vision and in comfort. She was in a lot of pain. Vision was correctable to 20/50, and she did have an epiretinal membrane, so that really was why I think I couldn't correct her any better. What I want to highlight in this case is that after 2 hours, this is what her lens looked like. And this is again, a more dramatic example of what we potentially can see, especially with, in the pandemic, patients are staring at the computer so much. And these scleral lens patients, when they're staring, they get that anterior surface fogging quite commonly. Now, this patient is far more extreme because she does have exposure keratitis and she's not able to fully blink. However, I still went through the basics of treating anterior surface fogging as I would with a normal patient. So I'm asking her, every hour, every 2 hours, I want you to force that blink, do a squeeze blink. I find that helps certain patients. I reviewed her medications. So I didn't mention it in the case because we're going through this more quickly, but she was taking steroid drops. She was using Lipo-6. So this potentially can get on the lens and compound the problems. So what's really critical is when a patient like this, you put that lens in the morning, their eye has to be clear of all of this stuff that can gunk up their lens. Okay. We treated the lid disease. So even though her lids are a little bit blurry in this picture, you can see the amount of atrophy. She's got lash loss, probably from the radiation itself, telangiectasia. So treating the lid disease is really critical to the success of these patients, whether it be, initial things like compresses and omegas or doing more advanced treatments like IPL and LipiFlow. I think we have to not be afraid of advising these patients to have these procedures. Anything foreign on the lens, I always go through that with patients. Patients still get soap on their fingers and get it on the scleral lens and then mess up the surfaces. Windshield wiper. So for those of you who don't do windshield wiper, it's great. So what you do is you get a Q-tip, use Opti-Free Pure Moist on the edge of the Q-tip, and the patient can actually go like this against the anterior surface of the lens. It doesn't clear up the lens all day, but it gives them a couple of more hours without having to take their lens out and clean it. Okay, so I tell, women, keep it in your purse, men, keep it in the car, whatever you want to do. It's an easy way of cleaning the lens for those severe dry eye patients. Hydra Peg. So Hydra Peg has been a godsend, I think, to ocular surface disease patients. This lady, I fit her several years ago, and Hydra Peg was not available in Canada at that time. Her current lens is Hydra Pegged. I do have a picture of her current lens right now. It's not in the deck, but it looks much better than what you're seeing right now. So we put all of these things together to make her lens better, and it improved. However, we still had the issue of the lid. And so I had bugged her oculoplastic surgeon over and over. We need to do something about that lower lid to help her because she complained about it so much. She was so bothered by the fact that she was getting fogging after a few hours. So he did a blepharoplasty. And, this is the scarring. The SPK or the peripheral epithelial erosions are gone. She is a much happier patient. Vision is 20/40, again, because the epiretinal membrane has decreased her vision. But these types of tidbits have really helped in clinical practice. Like, we need to go with that anterior surface fogging, go step by step through everything that the patient is doing to get to the endpoint where we can make them successful.
That's wonderful. So thank you for these great cases, Vishakha, and taking us through this journey. Hopefully the audience will appreciate, all these tips for these fundamentals of scleral lens success. And, I just want to close it, first and foremost, thank you. Really is an honor to have you host this webinar. I learned a ton, and I'm sure the audience did as well. And then we just wanted to say, we know 2020 was a tough year, right, for all of us, but fitting scleral lenses shouldn't be too. And so hopefully with these features and with us being your partner, we can help you become successful. So if you wanted to learn more about our features, please just visit our website, BostonSight SCLERAL.org. Follow us on social media. We have a Fit Group page where we share tons of educational content weekly, both from a fitting point of view, but also from a medical management point of view. We're also on Instagram, and we have a YouTube page. So thank you all for attending. Thank you, Vishakha, again. And so I know we're a little bit out of time, but we do have some questions. So for those attendees that want to stick around, Vishakha, what do you think about just taking some questions, and some of the questions that we cannot get to, just to be respectful of time, then we can follow up with the answers to these questions over email. What do you think about that?
Absolutely, absolutely.
That's wonderful. All right. So let's see. Wow. So we have an attendee from Cyprus. You know, that's one thing. We have people joining from all over the world. So Kyriakos, if you're still with us, thank you for joining. Let's see. David DeMarco, I fit my first 2 E2 patient fitting recently, and the patient had a toric over refraction, which removed the ghosting when going from E1 to E2. Is it common to get a toric over refraction with different eccentricity? Have you seen any, I can comment on this, but have you noticed this on your end, Vishakha?
So to be honest with you, I haven't fit a lot of the eccentricity 2 and compared it to eccentricity 1. So I think that in this case, we're probably better off answering that particular question, but I would assume, yes, that there could potentially be different toricity values. As you mentioned earlier, putting in more eccentricity will potentially, you know, use that word mask some of that toricity.
Yeah, so we have seen, David, sometimes we see masking, but sometimes we see some manifestation of residual seal, even though the vision actually improves. And also you have to bear in mind that, you know, sometimes the centration of the fitting lens that you're using from the one that you're using for refraction might induce some of that as well. But when you take that into account and you order the lenses, that is properly compensated on the back end for you. Let's see. In case number 1, there's a question for you, Vishakha. Well, for both of us. When we added the smart channel to Voltapin Guecula and we chose 400 microns, does it affect the integrity due to changes in oxygen supply of the limbal area and peripheral cornea? Just
So
by going deeper.
Yeah, I asked Jennifer a question too of like how, because we are, you know, there's a lot of space over the limbus, you know, and we're, you know, when we're learning scleral lenses, you know, we want approximately 100 microns over the limbus or to minimize that area. So I asked Jennifer if there was any issue there, and she said absolutely no. I think essentially just think of it as, from what Jennifer was telling me about that case, think of it as just not having that bearing in that area. You know what I mean? Taking the pressure off of that area.
Right. And, you know, for cases where any given practitioner wouldn't want the limbal area to be vaulted, you can specify that, because we can really limit the channels to the haptic portion and not necessarily encroach into the limbus. So that's something that is possible. But I would agree with you, not necessarily, and we don't see that. So they're pretty safe to apply. Some clinicians are wondering where can you get an endo count done? I'm not sure if they don't have access. I mean, clearly with a specular microscope, some you know may have access to a confocal microscope. But if you don't have that within your clinic, sometimes some academic centers, I'm not sure if you know, Vishakha, you have had experiences maybe, you know, trying to get collaboration and trying to get these measurements.
It is tough because you know, when I was at the Cleveland Clinic, I just walked down the hall and got it there. But being in private practice, I have to send it to one of the hospitals. I've tried ophthalmology clinics, but it's so technician based. Like a technician who is not spending a lot of time doing an endothelial microscopy or not putting a lot of effort into it may not give you a good result. So my suggestion is find, you know, where there is one in your area and stick to that particular place if possible, if you feel confident with those values. But I do think, like, if you ever, you know, shortcut that and do a fit on a graft patient without getting that endothelial cell, like I made the mistake once of fitting a scleral lens patient on someone who had a brand new graft, thinking, oh, I won't need an endo cell count, this is a brand new graft. And she immediately got corneal edema. So a lesson learned.
There you go. Thanks for that, sharing that. There's a practitioner that asked, how do RK patients do with scleral lenses? I will tell you that RK patients tend to be tough from a refractive point of view because their vision fluctuates. They're great patients for scleral lenses. I have had great success with in this patient population or particular condition. What about you, Vishakha?
Oh my gosh, there's no comparison between scleral lenses and RGPs. So when you're fitting an RK patient, the way I look at RK is similar to post-LASIK, which is similar to any kind of surgically changed cornea. It's irregular all over the place, right? There's no rhyme or reason to some of these corneas. And so when you fit with a scleral lens, you are vaulting that entire area. And so you don't have to worry so much as you would with an RGP, which will decenter, according to where, you have changes of curvature and elevation. So the centration that way is much, much better.
Absolutely. And so maybe I think we can entertain 2 more questions, and then, we will follow up for all of you that we didn't get to your question. Thank you for posting the questions. And what we will do is when we send a link to the recording, we'll send a Q&A with the answers to your questions. So there's a clinician, Vishakha, that asked, what are the limits in endo counts when you're fitting a graft patient, a PKP? And what is your recommended wear time for these patients? Do you want to start? I do have some thoughts as well.
And I have thoughts as well. So there's soft rules and then there's hard rules around that, right? So like I have a patient who has an endothelial cell count of 550, and he can successively wear a scleral lens. And I have a patient who has an endothelial cell count of 1200, and she gets corneal edema from it. So, I think really you do not want to fit anyone lower than 500 microns, but even then you're really cutting it close. I tend to stick around 700, sorry, I didn't mean to say microns, cells, 750 cells, is really where I kind of take, I think we can proceed. But what I often do, to be honest with you, is because with scleral lenses, we have our fitting sets, we can always order a lens and return it if we have to, right? I do a stress test. So with these patients, I'll put a lens on them and I'll say, you know what, I'm worried about your graft. Let's have you come back an hour later, 2 hours later, 4 hours later, whatever it may be, and see if there's any edema. Yeah. And that will give us a lot of information. And then that being said, there's some patients who say they only want to wear a scleral lens to drive. Say they've lost their license, they have no choice. Please give me a lens to drive, and they're going to develop corneal edema, but they only are going to wear it for half an hour at a time. Well, gauge that. You don't have to say a hard no to these patients.
Yeah, you can modify wear time. I agree with you with the endocell count. There's not a hard cutoff for the person that asked. We are very comfortable with 1,000 cells per millimeter square, but even up to 800 or so, maybe 750, like you said. But the key is to challenge the graft, and that's what I was going to say. We challenge the grafts even with a trial lens in office, and then have the patient come back after 4 hours, and it'll give you an idea. And so there can be options. So you can follow up with the consultants about what can we do from a fitting perspective. So the last question is, what is Hydropec? And that is a very a great question, because you and I, probably have been working with Hydropec for a long time, but a lot of our audience members, it seems like, this is new to them. So do you want to just quickly describe what Hydropec is, and then we'll close the webinar tonight?
Yeah, so Hydropeg, I usually, I didn't put the slide in. I usually put a Hydropeg slide in my presentations. So it's produced by Tangible Science, and what they have done is basically it's polyethylene glycol, and that polyethylene glycol embedded into the lens allows the lens to wet better, right? So I don't have access to Boost. Pardon? I don't have access to Boost. So if you want to talk to Boost as well, because I don't get it in Canada, but I'm dying to get it, you can reinforce that Hydropeg coating. But what's fantastic about Hydropeg is that for those really dry eye patients, it keeps the wettability going much longer, and really reduces anterior surface fogging as well.
And for the audience member, just so that you know, Hydropec is something that is available from Boston with BostonSight SCLERAL. So if that's an option that you want for your patient fits, you just click a radio button on Fit Connect, and we will add Hydropec to it. So one more time, Vishakha, I cannot thank you enough for your amazing lecture tonight. Thank you for all of the audience. We had a great showing tonight, Vishakha. Thank you for everyone who stayed past the webinar time just to host this Q&A session. We look forward to seeing you at our next BostonSight SCLERAL webinar, and we will follow up with a link to the recording and the answers to the unanswered questions. Thank you again, Vishakha. Have a great night, everyone.
Thank you, Karen, and thank you too for jumping in and taking over Jennifer's place. And thank you everyone for joining us today.
Thank you. Have a great night.
You too.